It's Richard, your acting CNE, here to bring you another recorded in-service. And this time we're going to be discussing the basics of ECGs. So this in-service I was able to hold last week on the unit, and thank you to everyone that was able to attend. But I thought I would continue on trying my best to record these as I'm able to help provide this information to people who weren't able to attend that day or weren't present on the unit. And hopefully, if you find this in-service helpful in any way, you can return to this to help sort of solidify the information that I provide you, because this is one of those topics that's not easy to comprehend or take everything in on first exposure. I know it's taken me quite a while to learn the essentials of ECG interpretation, but I hope this is helpful in some way, and I hope people are finding these recorded in-services helpful as well. And thank you to everyone that's been able to watch it and provide some feedback. And I want to give a special shout out to my mum, who decided to make a comment on the YouTube page as well. Thanks, Mum. Good to know I've got your support as always. And we'll get into this week's session. So, when learning about ECGs, I always think people just get quite overwhelmed when trying to understand it. It can seem like such an overwhelming topic and quite a difficult tool to interpret. But ECGs are just like anything. It's just if you break them down and practice, you will be able to learn it. Trust me, if I can learn this, anyone can. I guess the analogy I always use when it comes to ECG interpretation is like learning how to read. When you're learning how to read, you wouldn't offer someone War and Peace or Crime and Punishment as a book to first get started with. You would start off teaching them the alphabet, the sounds of the letters, and then providing them with those baby books, and then working your way onto a Green Sheep or Goodnight Moon. And learning ECGs is the same. We just need to break it down to its essentials and then do it as a building block process. And that's like any skill in this profession. Things can seem quite difficult, but if we can break it down and probably decomplicate how complicated we explain things, then we will find that these aren't as scary as you originally thought. But why? Why do we need to know about ECGs in B22? This is a gen surge ward. This is not a cardiology ward. So why should I even bother learning about this? Well, let's talk about why we would bother doing ECGs in B22 anyway. Sometimes they're required pre-op for people who are going to go under operations. Maybe they've never had an ECG done. If we do one, potentially we might pick up an abnormality like atrial fibrillation or a-flutter, which we'll talk about later. If a patient complains of chest pain here in B22, we often have to do that as part of our assessment. If the patient is suffering some electrolyte imbalances, which it seems to be the most common one in B22 is a high potassium, we would need to do an ECG. Again, we will talk about why we would need to do that later on. And when commencing certain medications as well. Maybe sometimes you've seen the doctor's note saying daily ECGs or monitor QTC. There are some medications that can affect the patient's cardiac function. If they remain on it for too long, it might put them at a risk of developing certain arrhythmias, and we just need to be aware of that. Again, we will talk about that as we progress. And during clinical reviews and MET calls, we often have to do ECGs as well. But first thing is first, we cannot talk about the ECGs unless we understand about the heart. There is no point me talking about all the fancy sinus rhythm and complexes unless we understand our fundamentals. So let's do a quick anatomy lesson about the heart. Looking at this image over here on the left, we have the heart itself, and what the ECG can tell us is if there's an abnormality in the arteries of the heart. So when blood pours into the right side of the heart, when it's deoxygenated, it goes to the right atrium, right ventricle. Right ventricle will push it to the lungs to get oxygenated. That blood will then travel to the left atrium, then down to the left ventricle where it gets pushed through the aorta, which we can see is the big red tube there. And the aorta transports blood around the body, but the aorta also leads to the coronary arteries that sit on the outside of the heart. The heart also pumps blood to itself. The muscle of the heart, the myocardium, needs oxygenated blood to work, to function. And if there is a blockage in these arteries, that is what can cause chest pain and can cause heart attacks. And depending on which artery is affected, that can be reflected on the ECG. So you can see down below the image of the heart, I've got the bullet points there. So the right coronary artery is often referred to the inferior artery. So inferior meaning you go to the back. The right coronary artery sort of goes towards the back of the heart. Then we have the left anterior descending artery, which is at the front of the heart. And the left anterior descending artery gets referred to as the anterior region. And then we also have the left circumflex artery, which is our lateral region, so to the side of the heart. So depending on which artery might be affected, each of these arteries line up with a particular segment on the ECG, which we'll talk about on the next slide. And in this other image is just to show you how the chambers of the heart work as well. And in between these chambers, the right atrium, the right ventricle, the left atrium, the left ventricle, we have our chambers of, our valves as well. There's the tricuspid valve between the right and left, right atrium and right ventricle. And between the left atrium and left ventricle, we have the mitral valve as well. So now we're going to talk about the layout of the ECG. Why is this piece of paper laid out the way it is? So you can see that there is different sections highlighted on this ECG. We've got our lateral area, inferior, and anterior. So if your patient comes in, is on the ward, and they're complaining to you that they've got chest pain, and we do our ECG, if the doctors or yourself, you notice changes in a particular group of leads, that can tell us which artery has been affected. So for example, if the patient is complaining of pain and they've got changes in leads 2, 3, and AVF, that is the inferior leads. And that would mean that the patient is having an abnormality in their right coronary artery. And so on with the lateral area and the anterior. So lateral is associated with the left circumflex artery, and anterior is associated with the left anterior descending artery. So it just helps us identify which region of the heart has been affected. It doesn't have to be in one artery, it can be in multiple ones as well. You will notice that there is a section that is left out, that is lead AVR, which is not typically associated with any of those three major arteries. That's not to say that it can't tell us anything, but that's probably a bit more advanced than the things that I do want to go over. Just talking a little bit more about the actual layout of this piece of paper, you will notice down below that that is not highlighted at all. So that is actually lead 2, which we will talk about soon. So lead 2 is already shown in this inferior section of the ECG paper layout. But that top half of the ECG paper tells us more about the structure and the plumbing of the heart, while this rhythm strip down the bottom of lead 2 tells us more about the electricity of the heart. So sometimes when people have strange heart blocks and abnormalities with the rhythm of the heart, it's quite difficult to tell in these small snapshots in the upper half of the piece of paper. So sometimes we need like a long 10-second rhythm strip, which is what we've got down there, to help tell us about the conduction system of the heart. So to summarize, up the top, depending on which group of leads have been affected, they can tell us which artery has developed an abnormality, and down below that can help tell us about the electricity of the heart. So now we would keep talking a bit more about the electricity of the heart. So what does the QRS complex actually represent? So you can see on our little animation here, we've got the electricity starting from that right atrium, starting from a region called the SA node, the sinoatrial node, and the electricity will travel down the SA node to the AV node, which sits in between the right atrium and the right ventricle there, and that will delay the signal of the heart for a split second so the blood can empty from the atriums into the ventricle, and then the signal travels down the ventricle pathway to make the ventricles contract and push blood where it needs to go. So basically the P wave represents the atriums contracting, the QRS complex represents the ventricles contracting, and that T wave represents the heart depolarizing or resetting. It's pretty much that simple. P wave, atrium contracting, QRS, ventricle contracting, T wave, heart resetting. So if you see all of these sort of characteristics on the QRS complex, that'll tell us that our patient is in a sinus rhythm, and lead 2 is what gives us the best idea of how the heart's conduction system is actually operating. But why does lead 2 show us that? Well, I'm glad you asked. Let's move on. So here we are talking about lead 2. So you can see that little image of the heart in the bottom left corner of the slide here. You've got RA and LL, right arm and left leg. And when you're putting on the dots on the patient's chest, RA is the white one and LL is the red lead. And that view of the heart that lead 2 looks at follows the more natural conduction path of the heart. So as the electricity is traveling from the SA node down the heart, lead 2 sort of more naturally follows that pathway. So that's why we are set up in lead 2 in CCU and ED and ICU when the patient's on a cardiac monitor. If you look around, they will always be set up in lead 2 looking at the cardiac rhythm. And if there's an issue with the conduction pathway, that is the lead that's going to tell us what is going on. And in this example, we have our P, QRST, P, QRST. So this patient is in a sinus rhythm. So abnormalities in terms of the cardiac electrical conduction system will be most often viewed in lead 2. Now, I don't want to spend too long on this one, but lead placement. How do we place the leads? Look, you can go over this in your own time, but essentially, when you're placing the chest electrodes, we should be starting at the fourth intercostal space and then working our way down. And I think most of us here would know how to do the lead placement. Just some little things to be aware of. Look, I can already hear my mentor in RPA CCU yell at me before I even mention this. A lot of the time, people are trying to put the leads on the wrists and down on the ankles. I don't even bother. I just follow what this image does because, especially in a met call situation, if the patient's shaky or jerky, that may give you a lot of interference. But there are the more, I guess, traditional nurses when doing the ECGs, they will tell you always have to put it on the lower ends of the extremities. But to me, the difference is negligible. But I don't think it really matters, to be perfectly honest. There is some minor differences, but if the patient is in a state where they're jerking and shifting around, this is probably going to give you the trace that will have the less artifact. So how do the leads work? So essentially, if energy is traveling towards a lead, you'll get a positive deflection. But if energy is traveling away from the lead, you'll get a negative deflection. So the leads are broken up into groups. We have our limb leads and our chest leads. And our limb leads will give the view of the heart from the frontal plane, as if you're looking at it from front on. And the chest leads will look at the heart from a horizontal plane, as if you've sliced the heart in half. So the heart is a 3D object. Try not to think of it in terms of like front and from the top down. It's a 3D object, and as energy leaves the SA node, it sort of travels in a wave throughout the heart. And all these views just can help tell us which region of the heart has been affected if there is an issue going on. Just as a point to note, so when I mentioned earlier that we use lead 2 because if energy travels towards a lead, you get a positive deflection, and lead 2 will give us the best idea of what's happening in the heart. So energy travels that way, towards lead 2. Look at AVR. It is looking at energy that travels in that direction. Nothing should be traveling in that direction in terms of the heart depolarizing. So later on, when we're looking at an example of a normal ECG, you'll notice that in AVR, the complexes should be pointing the opposite direction to everything else. But that'll make sense when we get to the example of a normal ECG. All right, let's just take a break and just admire how far we have come in terms of technology. So this is William Einthoven. He is the inventor of the ECG, and this picture shows you the very first ECG machine. I cannot even imagine having to lug this to a Met call. And he's sitting there with his hands in salt solution, I believe, to try and help with the conduction. I believe this was made in the 1920s. And as another bit of trivia, have you ever thought about why do we actually start at the letter P? Why not A? I will provide you the answer later to keep you hanging on. So I find it really helpful when trying to, when I was beginning my ECG journey, to break it down into a checklist, because otherwise you're just looking at this piece of paper and your brain does not even know where to begin. So I actually have more steps in this, but in terms of what we do here in B22, I think these 4 things are probably the essential things to think about when looking at an ECG. 1, what is the heart rate? Is it fast, slow, or normal? So we should know that a normal heart rate is between 60 to 100 beats per minute. The second thing is rhythm. Is it in sinus? Do you see that P, Q, R, S, and then T? And if you see that, does it repeat, repeat, repeat? If you do, then you know your patient is in some form of sinus rhythm. And if you don't see that, then that's when we probably need to get the team involved, or medical team or cardiology people involved, to see if this rhythm is something that needs to be investigated further. Intervals. So we will talk about that very soon. The QRS complex is actually broken down again into groups. You've got your PR interval, QRS, and your QTC, and those 3 aspects each have their own normal value. And shape. Do you see any ST elevation present? Is this patient having a heart attack? And can you notice that reflected in the shape of the QRS complex? So let's talk about the intervals. So this image shows you the PQRS-T wave, and then you can see that the regions here, there's the PR interval, QRS, and the QT sections. And each of these intervals have their own normal range. So your PR is the time it takes from the energy to leave the SA node traveling to the AV node, and that should be between 120 to 200 milliseconds. The QRS, which is your ventricles contracting, should be around 800 to 100 milliseconds, and the QTC should be less than 420 milliseconds as well. And that is the time it takes for your heart to sort of reset before the heart needs to begin beating again. Now, where do you even find all these images? I mean, you could try and measure it yourself by measuring the small square boxes, but next time you do an ECG, have a look in the upper left corner. You will notice that there is, or is it in the middle of the page? Anyway, somewhere on the top of the ECG piece of paper or on the EMR, you will notice that there is a breakdown of these values. And that is something that quite often cardiology will look at, or the medical team will look at when trying to determine what is going on with our patients when we have done these ECGs. So now let's talk about when you should be escalating your ECG. Often we just do them on the unit and then just let it sit there until someone wanders by to eventually look at it. So if your patient has complained of chest pain, this is why you should be doing it. So in that little image of the heart there, it's focusing in on one of the coronary arteries. And if there is a blockage in that artery affecting the flow of blood to the myocardium, to the muscle of the heart, that can starve the myocardium of oxygenated blood. And the myocardium needs blood to function properly. If it is starved of blood, it can become ischemic, and then eventually it can die. And if that area or that region is starved of oxygenated blood for too long and it does become ischemic, we cannot repair it. And also that can just obviously lead to a heart attack, which is quite a severe event. So how is that represented on the ECG trace? So image A, down the bottom there, you've got the normal QRS complex and there's a normal ST section. But when you look at B, you will notice that the ST segment is elevated. So that would mean our patient is having a STEMI, an ST elevated myocardial infarction. And this needs to be escalated as soon as possible. We need to be calling a met call if we do notice this and getting cardiology involved, because these patients need to get to the cath lab as fast as they can to open up that blockage and re-establish blood flow. These other images just show you other signs of ischemia. So if the ST segment is actually depressed or if the T wave is actually inverted, has changed direction, that can also represent ischemia. And those are signs that need to be escalated, as they may be new and we need to re-establish blood flow as soon as possible for these patients. Now, long QT, quite a difficult one to explain, but I'm going to try my best. And if this does not make sense, I apologize, but I will try my best. So sometimes when patients have been commenced on particular medications, usually antidepressants, it can affect it can affect the electricity of the heart. Now, a normal QT interval is shown here in this top image. That upper deflection, the R wave, look at the distance between the first R wave and the second R wave. The T wave should end halfway between that first R wave and the second R wave. So the end of that first blue box represents the halfway point. That is where the T wave should end. Now, in some patients who have a prolonged QT interval, if you look at the image below, that T wave has gone past the halfway point. So that means the reset period for this patient is taking longer than it should. But who cares? Why does that even matter? Why are we even looking at that? If we have a long QTC, what is the significance of that? Oh, I am so glad you asked. This is why it is significant. If you look at the very far left of this rhythm strip, you'll see the R wave, and then look at the next R wave, and the T wave is actually inverted in between those, and that T wave goes past the halfway point of those two R waves. And then eventually you'll see a long squiggly line here, and that rhythm is torsades or VF, and that rhythm is incompatible with life and needs immediate intervention. We need to get the pads on these patients and we need to be shocking them. So essentially a long QT means that our patients are at a higher risk of developing an arrhythmia, because that reset period is just taking too long, and the heart doesn't like doing two things at once. It likes to start, beat, reset, pause. Start, beat, reset, pause. And in patients with a long QT, that reset and pause period is too long, and the pause time is too short as well. And it may lead to the heart trying to do two things at once. It tries to beat and then reset at the same time, and the heart gets confused and it goes into this rhythm, and then we are in big trouble. So you would be hitting the red button and calling a met call if your patient looked like they were in a bit of distress, and we would need to get the pads on and we would be shocking them as soon as we could. So essentially, if you've noticed in the notes that the doctors want daily ECGs to monitor the QTC, this is the extreme of what could happen. So a normal QTC, to go back over it, should be around 420 milliseconds. So if you look at your ECG piece of paper, if you've done one for these patients and you notice that number is getting towards the 500, 600 millisecond value, they probably need to go to a cardiology ward to keep an eye on them. All right, now we're going to talk about hyperkalemia. Probably the most common reason you would need to do an ECG in B22. Well, anyway, since I've started in this unit anyway, it just seems like we've had quite a few patients develop high potassiums for whatever reasons. May not be generally our surgical patients that we had, but probably more common in our medical patients. So in hyperkalemia, there are some characteristics that can occur, and depending on how high the potassium is, it can alter the appearance of the QRS complexes on the ECG. So hopefully you can see that in that first image. If there is a mild elevation, 5.5 to 6.5, the potassium, you'll get a peaked T wave and a prolonged PR segment. And then moving down as the potassium gets worse, 6.5 to 8, there's a loss of the P wave, the QRS complex gets prolonged, and then in severe cases where the potassium is over 8, then you get this really widening of the QRS complex, and then it can lead to asystole or ventricular fibrillation, which is again very bad. So if you have a patient whose potassium is trending up, we need to be taking the steps to intervene as soon as we can by either administering the Resonium or administering the Actrapid and glucose IV push to help get that potassium out of the cells and reestablish a normal potassium. And if this is something that's chronically happening to these people, they most likely need a renal input to see what's going on with their kidneys if they're not getting rid of their potassium. And if we can, trying to put them on a low potassium diet as well. So just hold off on those bananas for these people. Okay, so at the start of, near the beginning of this presentation, I talked about when we were doing ECGs, the reasons for doing ECGs, it might be a requirement pre-op. And sometimes people, when we do them, we find that they can be in these rhythms, atrial flutter or atrial fibrillation. It can be quite a benign thing. They may have had this for quite a while and not realized. But the risk with both of these rhythms is that because the atriums are not contracting properly, they're either fluttering or fibrillating, they're not emptying properly the blood from one chamber to the next. And blood, like anywhere, if it sits anywhere for too long, it can develop a clot. So even inside the heart, if blood is sitting inside that chamber for too long and not being able to move properly because of these rhythms, and a clot forms, and we go ahead and do surgery, the clot may move and then move to the lungs, causing a PE, or it can cause a stroke as well. And obviously, that's something that needs to be we need to be aware of before these people go to surgery, because we may need to start them on warfarin. Oh, well, no, we probably pre-op we would be starting them on heparin or getting cardiology involved. And if they've been in AF and they're not sure how long they've been in that rhythm for, that clot might be quite large, and they'll probably have to go for a transesophageal echo to see how big the clot is, and then commencing them on any anticoagulation to break up that clot, and then revisiting the situation further down the line to see if we can either get them out of this rhythm or if that clot has been attended to. It's just essentially we want to make sure that the patient is not at risk of any complications pre-op due to these rhythms. I just want to talk a little bit about the different rhythms and what you can shock and what you can't shock. So on that left side, you'll see the shockable rhythms, ventricular fibrillation, ventricular tachycardia. So if the patient was placed on the monitor if we did an ECG and we saw either of these, I'd be saying, why are you even bothering with a 12 lead? Get the pads on them, we need to be shocking them. And then asystole, our flatlining, is a non-shockable rhythm. And this is the one I was like, what are you even talking about? Is this a thing? When I first started getting involved in cardiology, a pulseless electrical activity. So that looks like sinus rhythm, doesn't it? But what can happen is when these patients become unconscious and then we see this rhythm, but if you actually went to feel their pulse, you wouldn't feel anything. And you're like, oh, geez, what the heck do we do here? Again, call an arrest, and we're probably getting adrenaline into these patients and hoping fate is on our side in those cases. So, any questions? If you did have questions, I'm always happy to answer them. When you see me on the floor, you can always email me. This is just one of those things that I think I've just dumped so much information on you, and I don't expect people to retain all of this information after one session. I do think if this is something you are interested in, you need to go over this as much as you can and expose yourself to doing more ECGs and attempting to read them yourself. And it's just one of those things you have to attempt, make mistakes, and perfect it over time, like anything. And I just thought it would be good to provide a bit of background as to the reason why we do ECGs in B22. So if you were asked and you can sort of understand the theory behind why you need to do it, we can also notice the things that we need to escalate in a timely manner as well. Now, let's put some of this theory into practice. Let's look at a few ECG examples. So this is a nice, beautiful, normal ECG. There is nothing wrong with this one whatsoever. You got a nice PQRST complex going on, repeating. This example doesn't have the long 10-second strip at the bottom of the page. But remember earlier on in this presentation, I talked about lead AVR. So if you look at all other leads, the QRS complex is pointing up. But in AVR, it is pointing down. So if you remember, I said AVR looks at everything sort of traveling in a northwest direction. And energy doesn't travel in that direction at all. So when energy travels towards a lead, you get a positive deflection. If energy travels away from a lead, you get a negative deflection. So it is negative in AVR. And that is just one way. If you see that, I would know, okay, this person has had the leads put on properly for this ECG. And if I ever noticed it pointing up, I would be thinking, I think you've put the leads on wrong, and we would need to redo it. Look, AVR can tell us some things, but for the purposes of this sort of presentation, I'm trying to keep it as simple as possible, which I hope I've achieved, and I won't dive too much into what AVR can signify. Now, I would hope, comparing this one to the previous one, you can notice quite a big difference. So this is an example of a patient suffering a STEMI. They are having a full-blown heart attack. If you look at leads V1, V2, V3, V4, there is full-on ST elevation going on, and there's some ST depression going on in leads 2, 3, and AVF. So that is what we call a reciprocal change. Because there's been an effect in one region of a heart, that can affect a different region of the heart. So this, if your patient had been complaining of chest pain and you did this ECG, I would not be calling for a clinical review or paging anyone. I would be hitting that beautiful red button in the rooms and calling a MET call and saying this is a cardiac arrest situation, because this patient is probably imminently about to pass out and we need to intervene very, very quickly. So another example of a STEMI ECG. This one actually shows ST elevation in multiple regions. So leads 2, 3, leads 1, AVL, and then pretty much Vs1 all the way to V6 have display ST elevation. And this tells us that this patient has multiple arteries affected, and they need to be getting to the cath lab to reestablish blood flow pretty urgently. So the way that this ECG is displayed, this is actually from an ambulance. So when I used to work at RPA, and I'm sure Liverpool have the same thing, they have the LifeNet system. So if a patient has had an ECG in the ambulance and it meets a particular criteria, it'll get transmitted to the CCU, telling them that they need to get ready, or it actually gets transmitted to the ED as well, telling them that there's a patient inbound having an active heart attack and you need to be getting the cath lab activated. And I still remember to this day when I was working at CCU and RPA, and we on a night shift, and the alarm went off 3 times for 3 different patients experiencing STEMIs, and then just trying to accommodate was probably one of the more stressful times of my career. Now, this is an example of severe hyperkalemia. I don't know exactly what the patient's potassium reading was, but I would imagine it would be over 8. So this is not a great rhythm to be in. And at first, when you first look at this, you could think, oh, that's ventricular tachycardia. But it's not. It's too slow. So you need to be very careful when distinguishing between VT and high potassium, because the interventions are very different. Because for VT, we would shock the patient. But for hyperkalemia, if you shock the patient, you are making even more trouble for the person affected. VT is faster. VT is also in every single lead. So if you look at V1 and probably lead 1, they aren't showing those characteristics of VT, that consistent wide wave. VT is always present in all leads, and it's a lot faster than what this is showing. So if you had a patient and the pathology had come back and the potassium was over 8 and you did an ECG, this is something that you might find. Another example of a hyperkalemia on an ECG. This one shows you your more classic peak T waves. So again, if your patient had a high potassium, probably around the 7 to 8 mark, you may expect to see something like this, and we would be needing to intervene pretty quickly by giving that. Hopefully they've got IV access, so we should be giving that insulin and glucose infusion to help get the potassium out of the cells, and I don't know, potentially even needs to get to ICU to start some dialysis as well. And this is an example of someone in atrial fibrillation. So if you looked at the very bottom of this ECG display, you'd see that they've got a long rhythm strip of lead 2, and you can see that the distance between those QRS complexes just varies from beat to beat. So this patient's in an irregular rhythm, and if we did an ECG and saw that they were in AF, we would need to be establishing, is this something new or is this a long-standing thing? If it was a long-standing thing, are they on some form of blood thinners? Are they on warfarin, rivaroxaban, Eliquis? And if they are, if they're going for any surgery, then we need to be stopping that before they go for their procedure, and probably commencing them on heparin, as heparin has a shorter half-life and those other anticoagulants just stay in the system for a lot longer and can increase the risk of bleeding. And this is an example of a long QTC on an ECG. So probably not going to go into like trying to measure out the T wave, but I've just got a red circle over where you will be able to find the values on the ECG piece of paper. So circle the QTC, and there's a circle around the value, which is 566 milliseconds, which is quite long. So yeah, this patient would need to be in an area where they have continuous cardiac monitoring to make sure that they don't develop that arrhythmia of VF. So final message. Look, ultimately, we aren't expected to be masters of ECG interpretation. I've actually learned that the more I learn about ECGs, I don't really need to know because no one ever asked my opinion, but I love learning about ECGs, and I know what to escalate and what can be sort of left for the doctors to review at their leisure. But ultimately, I don't expect people to become prolific at reading them, but I just thought it would be good to be aware of what is going on when we're asked to do an ECG. Just because we're not expected to be a master, it doesn't mean that we can't be curious or we would want to know more. So if this is something that you want to know more about, trust me, I will talk all day long about these things. So if you've done one, you're not sure, come and show me and we can talk about it. And if you do, it's just like any skill. You just need to keep repeating. If you want to get good at this or bladder irrigation or chest drains or whatever it is that we do here in B22. So just trying to remember that analogy of not trying to give someone who's learning to read Crime and Punishment like Gromit's having over here, but starting off with those basics, learning about the alphabet, learning the sounds of the words, and then just building from there. So I hope this session was enjoyable. I was hoping to keep this shorter than the last one, but it looks like I've reached 37 minutes. Sorry I wasn't any singing in this one. But if you found this helpful, please let me know, and I hope I can in future now start to address some of the things that are more prevalent to the specialty of B22. I could keep talking about cardiology things all day, but I will try to make the next in-services about either something related to gynecology or urology, because that's also going to help me understand how I can help the staff here at B22 sort of develop our skills. So again, thank you very much for listening to this, and I'll see you next time. Bye.